The other type, again, it's not really pulmonary, it's extrapulmonary, it's has to do with circulation. Let me remind you quickly that the gas exchange has two steps. It's a ventilation and circulation. Ventilation is when the air enters from the atmosphere to the lungs, and then the exchange between the alveoli and the air. Now the alveoli will pass the oxygen and remove the CO2 from the blood. This circulation must be patent. So in this case, in pulmonary embolism, basically emboli, it's a traveling thrombi. So there's a thrombi like in DVT travels, and now it's blocking the pulmonary arteries. That blockage means the first step of gas exchange could continue because the airway is open and the alveoli are can exchange the gas, but there's no oxygenation will pass down to the blood because there's no circulation. That's what we call the relation between V and Q, which is ventilation and circulation. So for optimum gas exchange, we need both. We need the ventilation and circulation. This is a circulation problem. So there's a blockage in the pulmonary artery. Now, the number one, the most common reason or cause of this pulmonary embolism is, as you know, is DVT. DVT is a thrombi. There are thrombi in the lower extremities, and then when they move or dislodged because of mechanical movement or because of blood disorders, they travel, and then the first thing they usually go to is the pulmonary artery, and that's where it causes all the problem. Again, the majority of the cases are caused by DVT, but also it could happen after orthopedic surgery, what we call fat embolism, or mishandling of IVs when a patient receive IV air through the IV that can cause air embolism. Regardless, it's the same thing. Now there's a circulation problem. That's why pulmonary embolism is usually covered with cardiovascular. But let me show you again a quick hair animation of the DVT when it goes and cause a PE. Okay, so as you see, who's at risk? Again, number one is DVT. Anybody with flow issues, with the blood flow issues, especially in lower extremities, and most commonly people with sedentary lifestyle or blood disorders. So eventually they get a DVT. Immobility is the number one, followed by recent surgery when the aggregation of the platelets to that is activated because of bleeding. Recent bleeding also will increase. History of DVT, obesity, smoking, all these etiologies that can lead to pulmonary embolism. Now, this is a classical condition that you have a patient with DVT, they are hospitalized, and we want to make sure that this DVT doesn't dislodge, and so you want to keep an eye on your patient. All of a sudden you go to the room and you find your patient catching their breath, they have shortness of breath. So usually that's what happens if this dislodged and goes all the way through the vena cava to the pulmonary arteries. The first thing you'll see is sudden dyspnea, and depends on the volume. It depends on the size of the clots. The patient manifestation will change, but usually there's a sudden chest pain, shortness of breath, and hypoxia. And if it's large enough, you can see hemoptysis. The patient start coughing, and you can see blood in their cough. Now this could be a medical emergency that had to be treated right away. The patient will need to go to ICU. More serious conditions about restrictive and pulmonary circulatory problem will be covered in critical care. The classical symptom, or the standard procedure or diagnostic test to confirm the presence of PE is what we call the spiral CT, and we have other tests, but this is the test that will show you if there's a clot. Now, the other test I would like to introduce is what we call the D-dimer. D-dimer is part of what we call the coagulation panel, which include PT, PDT, INR, and fibrinogen. The presence of the dimer or elevation of the dimer, which is the end products of a clot that's being broken down, confirms 100% that there is a clot somewhere in the body. However, it doesn't tell us where it is. That's why we need to do a CT scan. So again, whenever the dimer is high, it means that there is a clot somewhere in the body. When it's normal, we can rule out or exclude the presence of a clot. Now, as far as treatment, again, the surgically it can be removed, but because of the mortality rate, we usually don't do that. But the option that we have as far as medication, we have TPA. TPA, this is again a medication that dissolves the clots. This is the only kind of medications, only group of medication that actually it goes and dissolve the clots. But because of the mortality rate and because again of the risk for bleeding, we don't usually use that, and again depends on the size of the PE. But because the patient has high tendency to develop more and further emboli, we may give them anticoagulant. Actually, we will be giving them anticoagulants, either heparin or Coumadin. I want you to remember that heparin is monitored, the effect of heparin monitors based on the PDT, and so we have to do a PDT every 8 hours to make sure if we need to increase the dose or decrease the dose, while Coumadin is done, depends on the PT and INR. And let me show you a video about Coumadin.